Okay, good evening and thank you for the introduction, Andres. So I've been charged with essentially giving you background to why we're here tonight. Why are we talking about coronary calcification so long after it was first identified? And the first reason is because it's common. We see it with great frequency and it's a real mechanical problem for percutaneous coronary intervention, both for the delivery of stents, for optimizing stents, and also outcomes following coronary angioplasty and stent insertion. But it's been around for a long time. As mentioned briefly in the introduction, calcified coronary artery disease was first described 40 years ago in the seminal paper by Andreas Grunzig, where he described plain old balloon angioplasty. And 40 years on, heavily calcified lesions still remain a challenge for successful angioplasty. And as again stated, tools to deal with calcific coronary disease have been around for a long time also. Rotational atherectomy first described in 1988, FDA approved in 1993. It's again 30 years old, and we're still using similar consoles today, although, disclosure, there is obviously the Rota Pro coming soon. And I thought the best way to describe or to give you an idea of the flavour of the impact of coronary calcification is to describe a case. So I'm going to briefly run through a case of a 71-year-old gentleman who has a variety of cardiovascular risk factors. He presented as an acute coronary syndrome and non-ST elevation myocardial infarction with a suggestion of LAD ischemia on his ECG. He had a troponin elevation and hit the cath lab 4 days after his initial presentation. These are the sort of first diagnostic pictures. As you can appreciate from the PA caudal image playing in the bottom left-hand corner of the screen, there's a significant heavily calcified proximal osteal LAD lesion. It's a dominant circ, which is relatively unobstructed. And in the areocranial image, again, we can appreciate the clear culprit lesion in the proximal osteal LAD with relatively unobstructed additional vessels. To have a close-up of this lesion, you can see quite clearly significantly calcified osteoproximal LAD disease with radiopacities apparent on the superior aspect of the left anterior descending coronary artery. It's a non-diabetic ACS presentation, single vessel disease, so the operator proceeded to angioplasty. Now, a standard balloon escalation strategy was initiated, initially with a 2.0 semi-compliant balloon, which is restricted, followed by a 2.5 non-compliant balloon, again with some restriction and wasting of the balloon in the proximal third, and then a scoring balloon, a 3.0 Scoreflex balloon, which again is restricted. And just to be clear, in a magnified shot, we can see in the proximal or middle of that balloon that the balloon hasn't fully expanded. Now, at this stage, there are obviously additional techniques that we're going to discuss in detail tonight that could be used to modify this lesion further or to get further information. And this is the coronary angiogram after the balloon angioplasty treatment. Now, despite the appearance of the balloons, the operator did proceed at this stage to stent implantation. And here we can see the positioning of a stent aiming to land the stent at the ostium of the LAD. And here is the stent up picture, showing clearly that the stent is up, aside from against the asymmetrical expansion against the proximal calcified lesion. Here is then the angiographic image after the stent insertion, clearly seeing the underexpanded and asymmetrical expansion of the stent in the proximal third. The operator then proceeded to try and expand the stent further against the calcium. And now there's a series of increasingly aggressive and larger non-compliant balloons to try and expand the stent fully. And most of the time, the next picture I would show, especially in a meeting, is a coronary perforation. But reassuringly here, we were just left with an underexpanded stent in the ostium of the LAD. So I think this case highlights important issues with relation to coronary calcification. It highlights it's frequent. The operator encountered significant calcific coronary artery disease, so we all can. It highlights the fact that angiographically, although angiographically often you underappreciate the presence or severity of calcification, hence almost the routine intravascular imaging which is required, again, which wasn't imaged in this case. And it also highlights the need for plaque modification with heavy coronary calcification prior to the insertion of drug-eluting stents, or even bare metal stents. And it also highlights, well, it doesn't highlight, but could have highlighted important complications that occur, coronary perforation because of aggressive post-dilatation of an underexpanded stent, and also the long-term outcomes of this stent in terms of restenosis and stent thrombosis. And these are topics that I'll cover in the next 10 to 15 minutes of the talk. So we know that coronary angiography has relatively low to moderate sensitivity for coronary calcification, but does have high specificity. High calcification, as you can see in the still image to the right, is readily apparent on coronary angiography, and a standard definition is radiopacity seen without cardiac motion prior to contrast injection, usually affecting both sides of the lumen, with moderate being within the cardiac cycle and not both. But we know that coronary angiography undercalls the presence of coronary calcification, with intravascular imaging studies, particularly with IVUS, showing that in up to 50% of cases we miss or underappreciate the severity of calcification. And we know that with significant calcification, imaging is helpful, which is all I'm going to say about intravascular imaging, because we have excellent talks coming up from both Kerry about non-invasive and Christos about invasive assessment of calcification. So I won't touch any further on imaging. In terms of prevalence, it's common. These graphs clearly depict that if we all live long enough, we're all likely to have a degree of coronary calcification. They also show that it's ethnicity dependent, with differences between ethnic groups. Irrespective, it's a common problem for all ethnic groups. Looking at the frequency of calcification seen within studies, this is a table showing essentially 13 drug-eluting stent studies with a pooled incidence of coronary calcification at the bottom. You can see that 29% of patients had moderate to severe calcification. And this is despite the fact that significant calcification was an exclusion criteria for a significant number of these studies. So it's an underrepresentative number. Moving on to a different study. So this is the Syntax trial and registry. You can see that there was the presence of heavy, so severe calcification, 1 in 2 patients. And these are patients we see on a daily basis. This is something that we're going to encounter. And it forms one of the key parts of CHIP programs, complex, higher risk and indicated patient programs, which are now numerous in number around the UK and the world, being a key component of coronary complexity, listed as a separate entity in its own right as calcium, but calcium will also play a significant component to CTOs, to left main intervention, bifurcations, treatment of the post-surgical patient. Calcium recognition and modification is important in all of these groups. And it's increasingly common. These are two different papers, both from the Veteran Affairs Registry from the United States, where we can see that over time, from 2009 up to 2015, there's an increase in the patient risk profile with higher rates of higher Framingham risk, with the bottom graph on the left-hand side depicting the rates of moderate to severe calcification in patients undergoing single vessel angioplasty in nearly 10,000 patients, increasing from 18 to 21% over a 6-year period. So we're all going to see these patients. What about here at Barts? Well, we don't routinely record that a patient has moderate to severe coronary calcification, so an exact figure is difficult. What we do know is over the last 2 years, we've seen a 50% increase in the use of adjunctive techniques such as rotational atherectomy, and nearly a 200% increase over the last 10 years. We started laser atherectomy and shockwave programs, both to indicate the need for additional tools to treat coronary calcification. And specifically looking at higher risk complex cases, of the 200 cases discussed in our local complex coronary MDT, 1 in 2 have previous bypass surgery and all have a significant calcific component. And 1 in 4, the indication and the reason why we're discussing them is for calcium modification techniques. It's a large patient population. So what are the implications? We heard in the introduction that this is an important topic and one that we need to understand the outcomes. And we know that heavily calcified coronary lesions are difficult to dilate adequately. that can be difficult to deliver stents, adequately expanding a stent, as I showed in the case, and therefore with higher rates of malapposition and stent asymmetry. And this can lead to higher rates of procedural complications acutely, so dissection, perforation, and longer-term poor outcomes, specifically major adverse cardiac events, with higher rates of stent thrombosis and restenosis. Now, if we look at the amount of calcium, it's important in your degree of stent expansion. And here a study, and the graph on the bottom right-hand corner depicts that the greater the arc of calcium, so the greater degrees of calcium found within the wall, the poorer your stent expansion or the reduced expansion. And we know that asymmetrical stent expansion is seen in up to 50% of stents deployed in calcific lesions. And we know from the literature, and a large body of literature, most of these papers not being in the last 5 to 10 years, that stent expansion on intravascular imaging is the strongest predictor of early stent thrombosis and restenosis with bare metal and drug-eluting stents. So stent expansion is important. It's important to expand, it's important to prevent adverse outcomes. And this does correlate or is associated with adverse outcomes in series of papers. And I've picked out 2, because otherwise I'd be here all night. And this is an analysis from 7,000 patients from the combined analysis of the Horizons AMI and Acuity randomized trials. They weren't powered or designed to look at calcification, and it's an analysis post hoc. But in these 2 trials, patients with severe calcification had significantly higher rates of adverse cardiac events and mortality at 1 year compared to patients with either moderate or no calcification. And these adverse events, it's a nice, should have corrected that, is maintained out to a longer period. So this is a pooled patient level analysis out to 3 years, showing that in 7 randomized controlled trials, pooling the data together, that at 3 years, significant calcification is associated with high rates of mortality and adverse cardiac events. And this is one of Christos's papers, so more information, seek him. So, what treatments have we got, or what treatments are currently available to try and improve outcomes in this patient group? Now, we know that for coronary calcification, lesion preparation is key. And lesion preparation means we can adequately expand a lumen and modify the plaque, and therefore can improve rates of stent delivery and improve rates of stent expansion, and therefore hopefully improve outcomes in these patients. And the current treatments, and we may have seen this slide before, consist of balloons, so compliant and non-compliant balloons, scoring and cutting balloons, scoring being typically the presence of a wire such as a scoreflex around the outside of the balloon, and a cutting balloon with actual barbs on the external surface, so a flex tone, the one we would use locally. And then additional tools to modify plaque, so rotational atherectomy, which I've mentioned already. Orbital, that's not available currently in the EU, and laser. Laser atherectomy, it's more, I would personally use it, I'm sure we'll hear more about it later on, but it's often not listed in guidelines as a tool to treat calcium, and it's more for moderate calcification or to deliver your devices or kit to be able to treat severe calcification, so to modify your lesion to be able to deliver a rotor wire, such as the sort of razor strategy where you would use laser and rotablation. Does altering the calcium improve outcome? Yeah. This is a study in 60 patients where using OCT imaging in, as I said, 60 patients with significant calcification, comparing patients who had rotational atherectomy or cutting balloons, which were used in 48%, compared to the 52% where they weren't. And in the patients with the plaque modification tools, there was fracture of the calcium, and this fracture was associated with greater minimum stent areas and improved outcomes, so less restenosis and less target lesion revascularization. What data is there for cutting balloons or conventional balloon technology? This is a study not necessarily from the greatest journal in the world, but shows the point that in a small series of 90 to 100 patients, cutting balloons have been shown or associated with better surface or stent areas and lumen gain compared to non-cutting balloons. But the data is slightly mixed, and some studies have shown a benefit compared to, and some haven't. And typically they would be used for mild to moderate calcification, not really moderate to severe calcification. You need something slightly heavier duty, but we're going to hear more about that later. Rotational atherectomy, I've got very few slides just because, again, we'll hear more later in the session. The observational data and registry data for rotational atherectomy is very good. It shows that you get improved outcomes, better angiographic success. The one randomised trial which looked at rotational atherectomy compared to not, so only in bailout, actually showed no real difference in angiographic success. But looking at the success, so the strategy success in 240 patients, and this was deemed to be angiographic success with no crossover and no stent loss, was significantly improved in patients undergoing rotational atherectomy compared to no rotational atherectomy in patients with severe calcification. And there was a big difference between the two groups. And from all our practice, we've had failed cases which have been difficult to treat without adjunctive techniques such as rotablation. And here's just an example case of a very long calcified lesion in a right coronary artery, which was failed without the use of rotational atherectomy, but after successful drilling, to use the technical term, there's a nice angiographic result. And as we've seen already, the use of this technology is increasing, despite the fact that it's been around for such a long time, and that's because the patient population are there. This image is unusual for our practice because there's the insertion of a temporary pacing wire, and it makes up there's a few number of patients who would have a temporary pacing wire insertion for rotation these days here. Looking at guidelines, the last guideline that really comments was 2014. There's a referral to both cutting and scoring balloons to say they can be used to modify lesions, and also the use of rotational atherectomy in the second column. More to emphasise the use in stent delivery, but I would emphasise its usage in plaque modification and stent expansion. Laser isn't listed, and again, it's more moderate calcification. Obviously, with such interest in calcium we discussed already, there are newer treatments. I've got a few slides just to briefly touch on intravascular lithotripsy or shockwave, which is a new technology to treat vascular calcium. Again, this is a technology, as a common theme here, it's a technology that's been around for 30 years, originally designed to treat kidney stones because sonic pressure waves preferentially impact hard tissues, the calcium, rather than soft. And now it's available to deliver this technology within a balloon that you would inflate within a coronary artery to preferentially affect the hard calcium rather than the soft tissue. And these videos just display the effect of the shock waves on hard lesions and no effect on the soft. There's little data so far to really, and no randomized data from a shockwaves perspective. There's a single Disrupt CAD1 study, 60 patients, which showed that there's high rates of stent delivery, so 100% with low adverse event rates. And future studies are ongoing, and we're a centre here for the future shockwave studies. Here's a calcium treatment algorithm to show that these treatment pathways are evolving all the time. This is courtesy of the people listed in the top left-hand corner. The main thing I think to take from this is the fact that we now have tools available in addition to rotational atherectomy, or some centres do, in order to treat calcified lesions, and the intravascular imaging is very important to assess lesions to determine your treatment strategy. And I won't say any more for the fear of ruining other talks. So to summarise, coronary calcium is becoming more and more prevalent in modern day cath lab practice, especially in the CHIP era. There's an ageing population, there's high rates of hypertension, diabetes, renal failure, all of which contribute to coronary calcification. And we know that calcified lesions are among the highest risk lesions we treat, both for short-term pain and suffering and risk, mainly to the patient, in terms of perforation and dissection, and we'd always quote a high risk for these procedures. And longer term outcomes. We know that if we don't treat these patients properly, they're going to have higher adverse event rates compared to people without calcification. And we know, or briefly touched on, that the presence and the extent of lesion calcification is angiographically underappreciated. We know that moderate to severe lesion calcification is associated with higher adverse event rates, and it's important to recognise, treat and modify this to improve these event rates. And we know that this is an exciting up and coming field. So the field for calcific lesions is heating up with more and more data emerging soon. Thank you.